Good day. My name is Mihalopulos, and on behalf of myself and my colleagues at Waterbury Hospital, we'd like to thank the Connecticut chapter of the American College of Surgeons for hosting this event despite these uncertain times. Today I'll be presenting an interesting case of a foramen of Winslow hernia that presented to our hospital as a bowel obstruction. I have no financial disclosures relevant to this presentation. The outline of my presentation is as follows. We'll talk about a brief introduction, discuss the case report, including the presentation of the patient, imaging, intraoperative findings, and our treatment. Then we'll move on to the discussion, which will lead us into the conclusion. As a general introduction, internal hernias are a rare etiology of intestinal obstruction, accounting for only 0.2 to 0.9% of cases. However, due to the risk of a closed-loop obstruction resulting in compromise of the blood supply, failure to identify and alleviate the obstruction can result in as high as a 49% mortality rate. More specifically, foramen of Winslow hernias account for 8% of all internal hernias, and although rare, should be recognized in a timely manner to avoid increased mortality. On the right side of the slide, you'll see types of internal hernias and their relative frequencies. Again, foramen of Winslow's representing approximately 8%. Now, to follow is a case report demonstrating a bowel obstruction caused by herniation of the cecum into the foramen of Winslow that was operatively managed. Patient RC is a 46-year-old female who presented to our emergency room with a one-day history of acute onset epigastric pain associated with nausea, vomiting, and obstipation. On presentation, her vitals were within normal limits and her labs were unremarkable, as was her chest x-ray obtained by the emergency room. Her abdominal exam was soft, mildly distended, but with severe tenderness on palpation of her epigastric region. CT imaging was remarkable for an abnormally positioned cecum high in the epigastrium herniating through the foramen of Winslow into the lesser sac. This is well depicted on our coronal CT image displayed here. The cecum was also moderately dilated with a transverse diameter of approximately 6.6 centimeters, and the terminal ileum was seen herniating into the lesser sac. On the axial CT image displayed on this slide, you can see that the herniation of the cecum has caused lateral displacement of the stomach. With concerns for an internal hernia and subjectively increasing abdominal pain and distension, the decision was made to proceed to the operating room. Intraoperatively, the cecum was found to be herniated through the foramen of Winslow, similarly as seen on CT imaging. The first of these three images demonstrates the herniated distended cecum as seen similarly on CT imaging. For orientation's sake, you have the liver superiorly, the stomach inferiorly, and the falciform ligament just to the left of the photo. Similar findings are seen on the second image with a more clearly depicted pylorus, and on the third image, we have a view peering into the foramen of Winslow. We initially attempted a laparoscopic reduction of the hernia, but this proved unsuccessful due to the distension of the cecum and the inability to reduce the hernia with solely manual traction. Therefore, we made the decision to convert to an open operation. A decompressive cecostomy was made, reducing the intraluminal pressure, and with gentle bowel traction, the hernia was able to be reduced. The cecum was found to be redundant, and therefore to prevent future potential herniation or cecal volvulus, an ileocecectomy was conducted as well. The patient had an uneventful postoperative course, and prior to discharge, she had return of bowel function and complete resolution of her obstructive symptoms. In general, internal hernias are caused by a protrusion of the viscera through the peritoneum or mesentery and into a compartment in the abdominal cavity. In our case, this was herniation of the cecum through the epiploic foramen of Winslow into the lesser sac. The epiploic foramen of Winslow is an orifice that allows communication between the lesser and the greater sac, anterior to the inferior vena cava and posterior to the hepatoduodenal ligament. This concept is well depicted in the image to the right of the slide. Foramen of Winslow herniation is rare due to the normal architecture of the internal organs that prevents them from entering into this orifice, as well as the normal intra-abdominal pressure that keeps the peritoneal orifice closed. There are three main mechanisms that contribute to herniation. Number one, excessive mobility of the viscera as seen with a redundant cecum. Number two, an abnormal enlargement of the foramen, which is typically a congenital anatomical variant. And number three, changes in the intra-abdominal pressure seen in conditions such as pregnancy. Regarding diagnosis, CT imaging remains the diagnostic study of choice. Findings include mesenteric adipose tissues and intestinal loops behind the hepatic pedicle, abnormal localization of the cecum as seen in our patient, gas and/or fluid levels in the lesser sac, which was well depicted on the coronal image previously displayed, mesenteric vessels stretching anteriorly to the inferior vena cava and posterior to the portal vein, and displacement of the stomach anteriorly and laterally as seen on our axial image previously displayed. Approaches to resolution include reduction of the herniated organ via gentle traction, opening the lesser sac via wide Coker's maneuver, or opening of the gastrohepatic ligament. And although an open approach remains the dominant technique, a laparoscopic approach has been gaining utilization. In conclusion, herniation into the foramen of Winslow is not a common occurrence, but once confirmed on imaging, must be corrected with prompt surgical intervention in order to reduce mortality. I'd like to thank you for giving us this opportunity to share with you this very interesting case, and at this time I welcome any questions.